DAISICON2025. We are going to start with the second day session here. We are happy to welcome Dr. Bhavdharani Madam and Dr. E. Subbaiah to chair this sessions today's morning. Over to you. Thank you.
Now I call upon Dr. Mahesh to speak on once a week therapy. So far we knew only the pros. Now he is going to explain both the pros and cons. Over to you, Dr. Mahesh.
Respected chairpersons, respected senior professors and my colleagues, a very good morning to all. At the outset, I like to thank the DAISICON organizers for giving me this opportunity. So the topic for discussion is once weekly therapy in diabetes, what are the pros and cons? So I will be talking about why once weekly therapy, what are the drugs that are available in this category, what are the pros and cons in real world use, and certain practical tips followed by take home message. So why do we need this once weekly dosing? So after all, our patients are going to take lifelong therapy, and at one point of time they will feel bored taking daily medications, and we practically see most of our patients skip their daily doses. So this once weekly therapy is an important innovation in diabetes care which improves the patient adherence and quality of life by reducing the frequency of injections. And with respect to oral drugs, the pill burden drastically comes down. So the patients are happy, the blood sugar levels are maintaining good. We will see certain things about the currently available drugs. So under the category of insulin, we have this newer insulin which is called as icodec. It is not yet available in India, but very soon we will be having this insulin. And among the GLP-1 receptor agonists, we have the dulaglutide, semaglutide and tirzepatide. And we also have the exenatide ER, which is once weekly injection again, which is not mentioned here. And among the oral category, we have the DPP-4 inhibitor, that is the trelagliptin, which is a once weekly oral drug. So what are the pharmacological strategies for these drugs? So with respect to this GLP-1 receptor agonist, particularly semaglutide and tirzepatide, after injection, these drugs are going to bind to the albumin. So there is a slow clearance from the body. So that makes it longer acting. So similarly with insulin icodec also, it is a designer insulin, long acting insulin. It goes and binds to the albumin, and albumin insulin combination or combo forms the depot from which smaller molecules or monomers of insulins are released very slowly over a period of 1 week. And third one is trelagliptin. So this is an long acting once weekly DPP-4 inhibitor, which has inherent long half-life of around 120 hours. It is because of the strong binding with the DPP-4. And this half-life extension enables once weekly dosing while maintaining the therapeutic response with most of these drugs. So about insulin icodec, this is the ultra long acting basal insulin with albumin binding and slow release. And the more important point is that once you give the first dose, it binds to the albumin molecules and then slowly gets released. But to attain a steady state, we have to give 3 or 4 injections. So only after the 3rd week or 4th week of therapy, a steady state will be attained. And this drug is not yet approved in India. And we have various clinical trials supporting the use of this drug and efficacy of this drug. The A1C reduction is on par with that of other available long-acting agents like degludec and glargine. So suppose if a patient misses a dose, so once weekly, இப்போ Sunday போடணும்னு சொல்கிறோம், ஒரு நாள் மறந்து போயிட்டாருன்னா, whenever he remembers, he can take the next dose. And adverse events like hypoglycemia is similar to that of other long-acting insulins like degludec and glargine. But when combined with other short-acting insulins or other short-acting sulfonylureas, the risk of hypoglycemia again increases. So semaglutide, this is a GLP-1 receptor agonist. I know all are familiar with this. It is used in management of type 2 diabetes and chronic weight management. Starting with a dose of 0.25 milligram, you can escalate up to 2.4 milligram once weekly. And again, when you are going to miss a dose of semaglutide, take within the first 5 days. Suppose Sunday எடுக்க வேண்டிய டோஸ்னா Friday குள்ள எடுத்தா ஓகே, அல்லது you can go for the next scheduled dose on next Sunday. So similarly, tirzepatide, this is a weekly once GIP, GLP-1 receptor agonist, and again this is used for type 2 diabetes and chronic weight management. there are large number of studies depicting the A1C reduction with these drugs and the cardiovascular benefits also. Start with 2.5 milligram once weekly, and you can escalate up to 15 milligram once weekly. Again, whenever a patient misses this dose, take within the first 4 days, otherwise go back to the next scheduled dose. So Trilagliptin, again once weekly oral DPP-4 inhibitor, it goes and inhibits the endogenous DPP-4 enzymes, and it is an approved drug in Japan, and it is being marketed in India by various companies. And again, the efficacy is on par with that of other gliptins like vildagliptin, and this is 100 milligram once weekly dose. The renal dosing adjustment has to be done with relation to the eGFR of the patients. So what are the problems that are associated with this once weekly therapy? What are the advantages associated with this once weekly therapy? So you have to consider this long half-life. So this long half-life is responsible for all the benefits that are obtained because of this drug. So you can see the icodec, the half-life is 196 hours. With semaglutide, the half-life is 168 hours, and with tirzepatide, it is 120 hours, and trilagliptin, 120 hours. So this long half-life and steady state plasma concentration improves the patient adherence. So once you tell the patient in the injection ஒரு வாரத்துக்கு ஒரு வாட்டி போட்டா போதும்னா patients will start accepting for this injection, and there are fewer dose reminders for the patients, so the compliance increases for the patient. And convenience, whenever a patients who are in busy schedule who forget to take their timely medications, again this drug is going to be a boon for them. So for people who are in busy life schedules and on polypharmacy, this drug is going to be a big boon for them. Again, this once weekly pill improves the patient satisfaction because of the reduced pill burden or reduced number of injections, ultimately improving the quality of life of the patients. And again, the steady pharmacokinetics of these drugs, as I told for icodec, after 3 or 4 injections, the serum level is maintained steadily. This greatly reduces the glycemic variability, which translates into reduction in the microvascular and macrovascular complications. So less number of pricks. For example, if a patient is taking once daily injection, he has to take 365 injections per day, but it has been now reduced to 52 injections per day. So it is very easy to counsel the patients about long-acting insulin. So the greatest barrier among insulin initiation is the pain of injection and the daily injection therapy. So once you talk about the reduction in the number of pricks, it is easy to counsel the patient and start insulin very early in the course of type 2 diabetes. So ultimately, because of all these advantages, the patient outcomes are going to be good. The glycemic control is very good, and complications are lesser in number. And patient also feels that patient may feel less like a patient with fewer reminders of illness. So ultimately, patient satisfaction is greatly improved. So now the problems with the weekly once therapy is because of the long washout periods. So you can see that icodec, the washout period is 9 to 13 weeks. For semaglutide, 5 to 7 weeks. For tirzepatide, 4 to 5 weeks. And for trilagliptin, it is not mentioned in the literature. Probably it is also again more than a week. So we hear that patients coming and telling that, sir, ஒரு இன்ஜெக்ஷன் வந்திருக்காம்ல, நல்லா சூப்பராக blood sugar குறைக்கும், நல்லா வெயிட்டை குறைக்குமாம்ல, அதை எனக்கு கொடுங்க அப்படின்ட்டு. They think that this is a magic pill or magic injection, but it is not so. So whenever you want rapid reduction in the blood sugar levels, you have to go for some other means of therapy. Whereas these drugs are used in a longer period of time, the blood sugar levels will come down only after 3 or 4 weeks. That has to be clearly explained to the patient. Patients will come and tell that they think that with one injection their blood sugar will come down. With one injection their body weight will come down. It is not so. A proper patient counseling is necessary because this is a longer acting agent. It has to be continued for a longer period of time. Only then you will get the benefits that are mentioned in the literature. So again, whenever you give this agent, you cannot adjust the dose after giving this injection. Suppose if the patient feels low blood sugar level, like because of the associated drugs like sulfonylureas or other shaft-acting insulins, you cannot again adjust the dose of this insulin for the period of 2 to 3 weeks because of the long washout period. That is one of the problem with this drug. And again, whenever the patient develops GI side effects like a prolonged vomiting, intractable vomiting, you cannot take back this drug. Once injected, it is already injected. So you have to wait for a longer period of time for the symptoms to settle, and this has to be explained to the patient well in advance before starting these agents. And missed dose impact, sometimes this missing the dose can lead to hyperglycemia, but generally because of the longer acting nature of the drug, this is not a big problem. And higher upfront cost, because all these drugs are acting in a once daily way, and these are new to the market, all are research products, they are costlier than the daily therapy. So that has to be considered before starting these agents. Again, you have to keep in mind the long half-life and long washout periods of these drugs. These are responsible for both the benefits as well as the disadvantages of these drugs. So you have to be very careful in selecting these agents. And some of the practical tips to avoid the complications: start slow and start low and go slow. So that's why for GLP-1 analogs, we start with lower drugs and gradually uptitrate once in a month. So to avoid the GI complications like nausea and vomiting. For missed dose, we have already seen. For semaglutide, take within 5 days. For tirzepatide, take within 4 days. And for icodec, as soon as possible. Whenever the patient remembers, ask the patient to take the drug. So this is more important, perioperative considerations. So whenever a patient is posted for some major surgery, these drugs are going to be a problem. So for other drugs, routine drugs like routine insulins and oral drugs, we can stop 2 or 3 days before and shift to shorter acting insulins. But with longer acting agents, these drugs has to be stopped at least 1 week prior to the planned surgeries. So with icodec, you have to stop before 1 week of the elective surgeries because of the risk of hypoglycemia during surgery and after surgery. We have to switch over to other types of insulin 1 week before itself. And with the semaglutide and tirzepatide, you have to stop 1 week before the surgery. And some authors suggest to stop before 2 to 3 weeks because of the longer washout period. And this is because these drugs reduce the GI motility. So whenever a patient is posted for major surgery, you have to consider that this patient is on full stomach. Suppose if it is an emergency surgery, the surgeons and anesthetists should be warned about this drug. Consider the patient as a full stomach and take necessary precautions before going for surgery. And regarding endoscopic procedures also, this drug has to be stopped 1 week or 2 weeks before the planned endoscopic procedures. So the final take-home message is, once weekly options are there among the insulins, among the GLP-1 receptor agonist, and also oral DPP-4 inhibitors. And this incretin-based weekly therapies are having greater evidence in reducing the A1C levels as well as the body weight of the patients. And with respect to icodec insulin, this simplifies the basal regimen with fewer injections, that is 52 injections per year, not 365 injections. So it will be very easy to counsel the patient to start insulin therapy very early in the course of type 2 diabetes. And you have to match these agents to the phenotype, comorbidities, tolerability of the patients, and access to the drug, and whether the patient can spend for the drug, and use these drugs judiciously only in those patients who are fit to take this drug. And you also should know the missed dose windows and how to restart the therapy. And you also should consider the long half-life and longer washout of these drugs. Thank you, one and all.
Very nice presentation, Dr. Mahesh. One thing practical is, these drugs are albumin bound highly. So these drugs, our serum albumin, our patient's ethnicity, most of the times it is limited to 4 milligram. So the albumin binding, because of its pharmacokinetics, the desired effects may be little bit different from the Western counterpart studies. So based on, because nowadays we have this, in Indian scenario, the albumin most of the times is up to 4.5 milligrams. So that 4.5 grams, so per deciliter. So it should be taken into account. So the exact once weekly, how the unbound drug, the effect may be more profound in Indian counterparts. That has to be only by experience we can fix whether the dosage and all, I think so. With this, I call upon the next speaker. Treat now or wait and watch, the dilemma of pre-diabetes, Dr. Adeline Reina, endocrinologist, to deliver her talk.
So at the outset, I'd like to thank the organizing team of DAISICON2025 for having me here today. So this is a very, not a topic of dilemma, but many times a controversial topic, but I will try to do my best and give the real view of how we really go about managing patients with prediabetes. So I'm going to do it in 3 parts. The part 1 will be to understand prediabetes from a newer perspective, to see are we really justified in treating prediabetes. Part number 2 will be to look at the consequences and comorbidities that are associated with prediabetes, to see if it's really worth treating it. And part 3 will be to look at the evidences that have shown if there are any benefits that we are really going to look at when we treat patients with prediabetes. So part number 1, to look at the understanding of prediabetes per se. I'm sure we are all very familiar with the natural history of type 2 diabetes and its progression. Now what you see here is the onset of diabetes may be at this particular point when patient comes in contact with us, but the entire process of hyperglycemia and the consequences of both the insulin resistance and the beta cell dysfunction starts way ahead, almost 15 years before the onset. And so this blue zone is the missed zone that we don't really see these patients often, and the entire process of hyperglycemia and its consequences have already begun. So this is not the onset of prediabetes that we are seeing. Probably we are seeing patients who have been in prediabetes for quite some time. Now when we look at the pathophysiology of prediabetes, the pathophysiology of prediabetes and type 2 diabetes are very, very similar. You can see, be it an incretin defect, be it an impaired glucagon secretion, beta cell dysfunction, insulin resistance, increased hepatic glucose production, whatever we have been naming and treating in type 2 diabetes, the same pathophysiology of is seen in the prediabetes. So the learning number 1 here is, with the understanding that we have with prediabetes, the pathophysiology of prediabetes is as good or as bad as type 2 diabetes, and therefore we have to take it a bit more seriously. Now coming to the diagnostic criteria, the lower limit of criteria was from 110 was changed to 100 milligrams per deciliter in the fasting state. Now by lowering the criteria, we are trying to improve the sensitivity of picking up patients with prediabetes, but at the same time we are kind of deceiving ourselves, thinking that more and more patients are going to revert to euglycemia and going to reverse their prediabetes and not just mere progression of type 2 diabetes. Now, when we talk about the diagnostic criteria, we have criteria for IFG, IGT and the HbA1c criteria, but unfortunately, only 10.4% of people are able to satisfy the ADA criteria of IFG, IGT and HbA1c altogether. So that kind of tells us that we have a huge chunk of patients who do not fit into these numbers and definition, but still have the progress of the prediabetes going on, and therefore we just should not go merely by numbers. So point number 2 here is, it is a continuum of dysglycemia that starts at the onset, and it cannot be defined or put into a closed number to really look at it from what we actually do with type 2 diabetes. The third important thing is the conversion rate. The progression of pre-diabetes to type 2 diabetes is quite varied in different population. Unfortunately, we as Asian Indians, we see a very, very high conversion rate of pre-diabetes to type 2 diabetes, making our patients potentially at risk of not just type 2 diabetes and related complications, but also the pre-diabetes related complications, and that's why we need to have a red flag on. Now, at the end of the understanding of pre-diabetes, what do we really learn? Now, this is the heat map which was shown in the ARIC study, which clearly showed that though the range of pre-diabetes with HbA1c from 5.7 to 6.4 is what we use, the clear increased risk of progression was seen in patients who had an A1C more than 6.1% and who had a BMI of 27.3 kilograms per meter squared and above. Of course, this is the Western data. We will not be able to extrapolate it for our population, but this gives us a fairly good idea that people who have an A1C more than 6% or more than 6.1% to be precise and a BMI more than 27.3 needs a very close attention because the risk of progression and complications are higher. Now, having understood about what prediabetes has with regards to the pathogenesis, we will now look into the part 2, which is the comorbidities and consequences that we see with prediabetes. Now, this is the meta-analysis of all the prospective studies that have been done with prediabetes, looking at the risk of cardiovascular events, all-cause mortality and cardiovascular mortality. And if you see, across all these studies, regardless of whatever definition has been used, be it an IFG criteria, IGT criteria, HbA1c criteria, and be it ADA criteria, WHO criteria, you can see clearly the risk of cardiovascular events, cardiovascular mortality and all-cause mortality were significantly high, very consistently across all studies in patients with prediabetes. Now, whether there is any difference between how we diagnose prediabetes with regards to risk stratifying these individuals for probable cardiovascular disease. Now, this is the analysis which was done, which showed that patients who had IGT, as shown in the dark blue bar, had a higher chance of all the all-cause mortality, CV mortality, CV events and stroke. Now, this again re-emphasizes the fact that it is the postprandial dysglycemia or the beta cell dysfunction that contributes significantly more to the macrovascular complications than the mere insulin resistance alone. So therefore, more than the IFG, the IGT was associated with a very strong association with macrovascular complications, especially the cardiovascular. And another observation from this study was to look, they have found that women who had IGT had a significantly higher prevalence of macrovascular disease, especially women with IGT more than women with IFG. And in a subset of population who were already treated with metformin, they saw a significant benefit when patients with prediabetes and a pre-existing CAD were put on metformin. The progression of diabetes was retarded. At the same time, the cardiovascular risk reduction was also observed. However, there was no significant difference in terms of heart failure. So the significant risk of cardiovascular events, cardiovascular mortality, all-cause mortality did exist in patients with prediabetes. Now, how about the other complications and comorbidities? Now, the prediabetes was again associated with cancer, dementia, depression, cognitive dysfunction and several other disease, and this again tells us that the other pathophysiology of the Alzheimer's disease and the neural contribution for pathophysiology of prediabetes and type 2 diabetes still holds good, and we need to probably keep it in mind, especially when we see patients who already have a pre-existing dementia or a cognitive decline, probably should consider treating the prediabetes. Now, putting together all the complications of prediabetes with regards to progression of type 2 diabetes, progression to CKD, cardiovascular disease and all-cause mortality, regardless of whatever criteria we use, be it an ADA criteria, WHO criteria, whether it's going to be IFG, IGT or HbA1c criteria, the risk of developing complications is very clearly, undoubtedly high. But when you look at the parameters that were used to define the prediabetes, the HbA1c more than 6% had a very strong predictive value for all the complications, both micro and macrovascular complications. So therefore, HbA1c more than 6% probably should give us a clue that that is an individual who is going to progress into cardiovascular and microvascular complications. So putting all these understandings together with the associations and comorbidities, we can come to a reasonable conclusion saying that probably there is a rationale to treat prediabetes, not just for the mere reduction in the progression towards type 2 diabetes, but also to prevent and probably postpone the complications, both micro and macrovascular complications. Now let's move on to part 3, which is the evidences to show how treatment of pre-diabetes could be beneficial. Now this is the lifestyle intervention trials, including the Chinese darking trial, DPP study, which all primarily focused on weight reduction as the driving factor for the treatment of pre-diabetes, and we understand that the primary benefit was through weight loss, and it did show a legacy effect over a period of time even after the trial was completed. And the most important thing is, from the DPP-OS study, we see that the benefit was seen even after 15 years after the completion of the trial with regards to reduction in the progression to type 2 diabetes, and there was no cardiovascular data at that particular point of time. Now, how about the pharmacological therapy? We have so many trials that have been done in patients with pre-diabetes, right from STOP NIDDM, DREAM trial, Navigator trial, ACT now, even until the SCALE trial, which was done with liraglutide. Of course, these were all short-term trials to the maximum period of 4 to 5 years, and it did prevent the incidence of type 2 diabetes. However, these are the trials which were not primarily focused on reducing the complications of pre-diabetes. So of all the treatments that were given, metformin showed promising to be with regards to reduction in the incidence of type 2 diabetes, especially in younger, obese, and women who had a previous history of GDM. Of course, there are no data on the long-term benefits of pharmacological therapy, and we really don't have data to say how long should we treat pre-diabetes. Now, this is from the ORIGIN trial with insulin. Again, did show a reduction in terms of progression to type 2 diabetes with glargine insulin. And this is a trial which STOP diabetes trial, which showed the combination of metformin, pioglitazone, and GLP-1 RAs to tell us that a reduction in the progression of the IGT. Now, we have newer agents like what was discussed in the previous session. We have the GLP-1 based therapy. The semaglutide in the STEP 1 trial again showed that patients did show a significant reduction in the progression to type 2 diabetes. And tirzepatide in SURMOUNT 1 trial showed again a very, very clearly lower incidence of type 2 diabetes in patients who had pre-diabetes and obesity. Now, macrovascular risk reduction, again, all the trials done previously with older agents did show a benefit with regards to macrovascular risk reduction with MACE reduction, cardiovascular event reduction, and cardiovascular death reduction. But when it comes to the microvascular complication, what the Chinese darking study showed was there was a significant reduction in diabetic retinopathy, but no major benefit was seen with nephropathy or neuropathy. So that way, retinopathy, yes, the benefits are there, but nephropathy and neuropathy, we don't have clear benefit with regards to treating pre-diabetes. So what does the guidelines say? The ADA, NICE, and ESC recommendations are only for metformin, especially when the BMI is more than 35, age about 25 to 60, fasting more than 110, HbA1c more than 6%, and a previous history of gestational diabetes. So these are the recommendations that have been put forward by ADA. Of course, we don't have very clear cutoffs or targets that we really need to look at when treating pre-diabetes. Bariatric surgery, again, significant reduction in the progression to pre-diabetes to diabetes, and therefore we also have newer agents like microbiota manipulation, zinc supplementation, all of them primarily targeting the reduction in the risk of developing type 2 diabetes. Now, how about the complication? This is the only trial, a prospective trial, which looked at treating pre-diabetes to look at the risk of cardiovascular disease events and mortality. And what you see here in the red broken line is patients who have achieved normoglycemia, which means a reversal of pre-diabetes to normoglycemia did show a reduction in the cardiovascular disease, myocardial infarction, stroke, and even all-cause mortality. So there is a clear macrovascular benefit prospectively when we treat patients with pre-diabetes. Now, there are a lot of unanswered questions. Should we reverse pre-diabetes in all patients? The answer is we don't know. And are we just preventing progression of diabetes, or are we just treating hyperglycemia early because of the numbers that we really have? How much to give? How long to treat? We have absolutely no data to support the treatment of pre-diabetes as of today. So to summarize, I would put points that would favor a treatment of pre-diabetes. Of course, the first most important benefit is it does reduce the incidence of type 2 diabetes. Number 2, reduces diabetic retinopathy, but no major change in CKD and peripheral neuropathy. reduces the risk of cardiovascular disease, mortality, and stroke. And of course, the agent that has been recommended with the long-term data is only metformin. Of course, GLP-1 RAs and tirzepatide should have some benefit with a long-term study. What we now have is only a 2-year-old study. Now, what are the factors that favor wait and watch? There is no benefit of treating them early than treating them late. And again, the second important thing is cost versus long-term benefit. How much of cost is going to be invested on treating pre-diabetes? The third point is we don't have drugs to actually treat the pathophysiological abnormality that is causing pre-diabetes, but we are just trying to achieve weight loss and manipulate the beta cell dysfunction to get some time or buy some time to develop type 2 diabetes. Last but not the least is the pre-diabetes is not the only factor that drives the entire macrovascular outcome. So treating pre-diabetes alone may not be really prudent for us to, if you're really looking at reducing the risk reduction. So my take on the treatment of pre-diabetes is no more a risk factor for type 2 diabetes. It is an individual pathological abnormal state that we really have to keep in mind. It does have an increased risk of micro and macrovascular complications. The lifestyle intervention still remains to be the most important and an effective tool to combat pre-diabetes. Of course, we now have pharmacotherapy to help us give and offer additive benefits to our patients with pre-diabetes. So pre-diabetes, treat or wait, I would say we need to look at the individual patient, risk stratify them, look at the risk of all the complications, and then consider treatment after a shared decision making. So thank you very much, and I will stop here.
Thank you, Dr. Adeline. Very wonderful, clear explanation about pre-diabetes. Now we'll move on to the next, the most important part, what we most of us are neglecting by our great academic person, ever vibrant, ever academic, Dr. Shanmugavelu, the psychological support and mental health in diabetes care. Over to you, sir.
Respected chairperson, senior doctors, my doctor friends, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on this particular topic. I am not, of course, a psychiatrist. So, psychosocial support and the mental health in diabetes care with a particular focus on evidence-based findings. I thank the organizing committee members as well as the chairperson for the nice introductions. My disclosures, what I am going to do for another 15 minutes. The contents of my talk line includes introduction, prevalence, the burden of a lifelong journey, psychological reactions, interrelationship between diabetes and emotional well-being, of course, psychological therapies and strategies in the treatment of diabetes. So most diabetes care guidelines concentrate on the medical aspects of initial management, often overlooking the critical psychological requirements of the patients. So many patients with the diabetes, they effectively manage their conditions and maintain healthy lifestyles. But of course, multiple studies reveal that the psychological support for the patient population remains under-resourced and inadequate. So it is quite challenging for patients to accept the necessity of lifelong medications, resulting in suboptimal treatment adherence and diabetes self-management. These psychological issues have impact on the self-care practices, metabolic health, as well as quality of life. So, recognizing the significance of psychological interventions, various authoritative entities have integrated evidence-based guidelines for psychosocial care in adults with diabetes. So, prevalence. So, meta-analyses conducted in India indicate a pooled prevalence of depression, approximately 38%. So, rural residents and those from lower socioeconomic backgrounds demonstrate high rates of depression. And a systematic review published, there was 41% increased risk of anxiety disorders, and patients with anxiety disorders, they face as high risk for developing type 2 diabetes. And review of Indian studies reported factors influence depression, female gender, young age, unmarried status, poor social support, low socioeconomic background, socioeconomic deprivation, and so on. And individuals with type 2, they often experience poor sleep quality and poor patient-reported outcomes, and the prevalence of depression females well documented because of unique psychological challenges, societal expectation and discrimination, and significant hormonal changes during pregnancy. And of course, genetic factors also contribute to both diabetes and mental health disorders, and individuals with the family history of both these conditions are potentially at high risk. Next is engaging physical activity. Limited physical activity has been associated with the onset of mental health disorders in patients in this particular population. And Very important thing is blood glucose monitoring, adherence to medication regimens and lifestyle management contributes to increased psychological stress and distress. Anxiety stemming from potential diabetes related complications. And patients with the diabetes, they lack social support. They face an increased risk of experiencing depression. Similarly, barriers in accessing healthcare services can also prevent patients with the type 2 from obtaining appropriate care for both physical and mental health requirements. So, there is a complex interactions between biological, psychological and social factors that contribute to the development and management of mental health disorders in patients with the type 2 diabetes. So, the different pathways of interaction between diabetes and mental health disorders. We have mental health disorders which can increase risk for diabetes, and patients with the diabetes, they develop increased risk. And the common risk factors being introitin influences, socioeconomic disadvantages and hazardous lifestyle. So mental health risk factors in patient. We have the biological risk factors like obesity, psychological factors like female gender, sociological factors like social support, marital status and living alone. So burden of lifelong journey. Managing a chronic illness can have a substantial emotional impact, especially financial expenditure, routine healthcare consultations, potential complications, emergency department visit and hospitalization, out-of-pocket medical expenses, indirect costs, that adds financial burden, impact of social determinants of health, and disparities in social economic status, major contributor for the associated complications. They of a patient with the diabetes, they often experience fluctuations in blood glucose levels due to anxiety, exercise, and hormonal changes. And those patients with a fear of hypoglycemia, they may not take sufficient insulin dosage, and they show increased vulnerability to complications arising from hyperglycemia. And stigma surrounding diabetes, that is always pervasive. It refers to negative attitudes, judgment, discrimination, or prejudice that someone experienced because of the diabetes. And stigma surrounding diabetes is always perceived, and they conceal self-management activities such as insulin administration in public settings. Weight stigma adds diabetes stigma as negative attitudes and prejudices. And when pediatric patient with the diabetes reach adulthood, support from family, friends, and the treatment team during the transition is crucial. It prevents a fragmentation of the care team. So leads to, and a very important thing is sustained self-management ability is very important. And next is psychological stress induces metabolic changes. And response towards stress varies in both type 1 as well as type 2. And this variability can be attributed to autonomic nervous system dysfunction. And emotional disturbances correlate with suboptimal glycemic control, poor self-care practices, and adverse diabetes outcomes. And non-adherence to treatment regimens has been identified as a critical mediator between emotional distress and poor diabetes outcomes. So reduction in depressive symptoms has been shown a positive association. So psychological factors including self-efficacy, self-esteem, and diabetes coping mechanism and social support were found to be associated with enhanced treatment adherence and glycemic control. Next, ongoing environmental pressures and diabetes-related distress were typically correlated with poor glycemic control. Psychological factors may contribute to metabolic, gastrointestinal complications, and sexual dysfunctions. So, psychological reactions. So, psychological factors in diabetes leads to poor glycemic control. Self-care behavior and treatment adherence reduce quality of life and increase diabetes-related complications. So, diabetes distress, it's a unique, often hidden emotional burden. Symptoms include frustration, fatigue. And this diabetes distress is different from major depressive disorder, which is a psychiatric disorder that arises from the emotional challenges. These are all the differences between diabetes distress and diabetes depression. So distress is an effective response. The prevalence is greater and seems to be linearly related, not a significant risk factor. Whereas with reference to depression, the prevalence is relatively lesser, but of course there is a reciprocal connection and it is a significant risk factor. Next is depression. 10% higher among adults with diabetes, and leads to obesity and diabetes through lifestyle factors such as sedentary habits, overeating, neglect of self-care routines. Next is diabetes on the other hand, it can precipitate depressive symptoms due to major emotional, social, medical and economic challenges. Antidepressant medications, particularly with the newer agents, induces weight gain, insulin resistant, thereby contributes to type 2 diabetes. And the risk factors common to both depression and diabetes include abnormal fetal development, socioeconomic disadvantages, and unhealthy lifestyles, and chronic hypercortisolism, prolonged sympathetic nervous system stimulation, And hyperglycemia is implicated in neurodegenerative process and also in the brain. And diabetes is characterized by chronic inflammation, predisposition, depression through its impact on synaptic and neuroendocrine function. Antidepressants may adversely affect the glycemic control. Next is anxiety. Patient often navigates dietary restrictions, intricate medication regimens, CGM that could foster symptoms of anxiety. Presence of anxiety may influence dietary choices, physical activity, leading to impaired glucose homeostasis, and coexistence of diabetes and anxiety may be associated with suboptimal glycemic control. Eating disorders, persistent disturbance of eating or eating-related behavior. We have three main categories: anorexia, bulimia, and binge eating disorder. And of course, diabetes is associated with increased susceptibility for all three eating disorders. We have the hedonic. So we know the center that is located in the mesolimbic area. We have the center in the prefrontal cortex. When get activated, they result in the eating disorders. And patients with the diabetes deliberately skip their insulin doses, oral hypoglycemic medications to reduce weight. And common disorders include the female gender, weight gain, and body dissatisfaction. Other psychiatric disorders in diabetes: delirium, often characterized by concomitant occurrence of the hypoglycemic episodes or DKA, and outcomes such as disorientation, confusion, altered sensorium. They are commonly observed in these patients. Next is other psychiatric disorders including schizophrenia and diabetes with approximately 20 to 30%. Emerging evidence suggests that insulin resistance may serve as a link between the affected disorder and Alzheimer's disease. Fluctuating glucose levels leads to the formation of neurofibrillary tangles, the hallmark of Alzheimer's disease. So, interrelation between diabetes and emotional well-being. Stress is a condition of tension, prolonged activation of the stress mechanisms. Then emotional strain is linked to unhealthy lifestyle patterns, and sustained physiological stress induces chronic activation of the hypothalamic pituitary adrenal axis as well as sympathetic nervous system. So prolonged stress, adverse changes in lifestyle, hypercortisolism, overactivation of the sympathetic nervous system, and inflammation in turn leads to the onset, progression, and complications. So diabetes and mental psychological dysphoria. So diabetes results in mental dysphoria, in turn results in limited physical and emotional functionality and leads to obesity, overweight, diabetes and diabetes-related complications. And the health effects of emotions. Positive emotions such as happiness, excitement, correlated with enhanced health behavior. Direct physiological effects include activation of the autonomic nervous system, hypothalamic pituitary adrenal axis, and the impact on immune function as well as lymphoid tissues. And healthy behaviors such as engaging in physical activities triggers the excretion of endorphins leading to sensation of elation. And negative emotions, stress, anxiety, depression are connected with impaired immune function that results in very high levels of pro-inflammatory cytokines, in turn results in inflammation and the onset and progression of diabetes-related complications. They contribute to prolonged infections, delayed wound healing, as well as the elevated pro-inflammatory cytokine production. So psychological therapy strategies in the treatment. So psychological screening and management at every level of diabetes care is essential. It is crucial to sensitize healthcare professionals, patients with the diabetes and their family members regarding the significance of psychological screening and intervention along with other recommended treatments. ADA position statement advocates for screening during the initial visit at periodic intervals whenever there is a change in disease condition. These best practices are often overlooked in clinical situations. So therapeutic interventions include psychosocial support as well as psychopharmacological agent. We give the guidance on self-care, cognitive behavioral therapy, social supporting network, psychopharmacological agents, and recommendations for clinical practice with reference to holistic care that includes emotional needs as well as social circumstances. So conclusion, the relation between diabetes and psychosocial disorder is multifactorial. Their coexistence can impact glycemic control, self-care routines, and quality of life. The emotional and psychological requirements are often undermined, leading to an increased risk of diabetes-related complications, higher mortality, increased healthcare expenses, and lost productivity. Addressing the psychosocial needs would help improve health outcomes and better glycemic control. It is important to address mental health symptoms of patients with diabetes in a consistent and ongoing manner as part of diabetes treatment. Before I conclude, I invite all our delegates to get their name registered for this 53rd Annual Conference of RSSDA that is going to be conducted from November 6 to 9, Kochi. So, these are all the latest flyer that has been circulated all our members. So, please make this a memorable and a successful event. Thank you very much for your kind listening and patience.
Thank you very much, sir, for the elaborate talk. Vande Bharat Express. Excellent.
Yes, sir.
Excellent elucidation. What I mean is excellent elucidation of interconnections between diabetes and the mental health, both bidirectional. Way.
Yes, sir. In short,
thank you.
in short.
That's what I said. All packed and fast game momentum. Before this sum up, the forum is open for a short discussion.
So as you rightly pointed out, in our busy practice, we do ignore this, which is a very important thing.
Very
That
important,
is,
madam, very
at the
important.
time, the diagnosing itself is a very great stress for the patient, and further we need to counsel all the family members, and further if they get into, many a time they land up and come to us with complication itself. We just see the problem what they have, and we do not care about the stress, psychological support at all. You clearly, extensively explained everything.
Madam, actually, we need to keep one workshop on this particular aspect in the future conferences so that we can elaborately discuss how to manage, how to screen early.
Yes, very important, because in the family itself, the mother and child, daughter, or the husband and wife, father, mother-in-law and daughter-in-law, like this continuous stress is there in the family. We need to think about it. Now it is open for discussion.
But the GLP-1 analog, in patient, now many of the young women with infertility, with obesity and PCOS, they have been exposed to GLP analog for weight reduction before getting conceived or before going for IVF treatment. So such women, we have been, what I personally feel is that know about us, at least you have to have 4 half-life to be considered withdrawing before, so because at the tissue level you might have GLP-1 analog. So what's your take? You have to withdraw it at least 4 weeks prior to the IVF treatment.
Yeah, any planned pregnancies like IVF treatment or IUI treatment, we have to stop this drug at least 4 weeks before the planned treatment. So that is being practiced.
And about the Icodec, you said you should be stopping it before the surgery. I could not get that.
See, because of the long-acting nature of this Icodec insulin, for major surgeries, it is better to stop 1 week prior to the surgery and switch over to other types of insulins like short-acting insulin 1 week before the surgery to stabilize the blood sugar.
Just to avoid hypoglycemia during
just to
because
avoid
basal insulin usually we say prior to surgery you don't need to withdraw. It's a basal insulin. When you talk about glargine in regular practice, we say that glargine can be continued. You can change your bolus insulin in basal bolus therapy. But here you are saying that long-acting Icodec is to be withdrawn.
It has been mentioned in the literature that 1 week prior to any planned major GI surgeries, it has to be stopped.
So maybe in future it's a scope for all of us for the research about Icodec in the pre-op cases. Yeah, thank you.
No, he is asking about Icodec, sir.
Once a week insulin. Now there are recommendations that the drug should be stopped at least 1 week before planned surgery, because we don't know. It's not about hypoglycemia alone. It is about the anesthetist. In fact, he did focus in one of the slides that anesthetists are very particular that the drug should be discontinued. Not because mere overnight fasting is not enough. Sometimes they may go in for post-operative vomiting and severe aspiration pneumonitis. That is one of the reasons. And I have a question to Dr. Magesh. You said that, in fact, I was part of one of the advisory meetings. I raised this question. You said you miss on a Sunday, take it on a Wednesday. Then what happens next Sunday? They were not able to answer this question. And then I also asked, what happens if there is an episode of hypoglycemia in between? These patients are going to be on other drugs also. So again, I was shocked and surprised when the pharma people said that they have not looked at this problem during the phase 4 trial. They have no answers to this. So this is a serious problem.
Yeah, generally, what I do is whenever a patient skips the dose, we ask them to go for the scheduled dose of the next week. Because of the long acting nature of the drug, there is. Yeah.
No, Sunday, Wednesday, again Sunday. So as Dr. Professor Subbaiah rightly pointed out, many of our patients are hypoalbuminemic. And there are going to be a lot of free drug in the system. Again, they take it after, say, about another 3-4 days. What are the chances of adverse events?
There's a mention of the long-acting drugs. Takes long time to hypoglycemia, normoglycemia. But my experience with tirzepatide and semaglutide weekly ones, by third day the sugar comes to normal. I don't know. Yeah, such a rapid acting. Anybody's experience there? Using
Probably some of
And madam, your prevention trials, your prevention trials has shown that a lot of people go to remission with pioglitazone, rosiglitazone, troglodyazone. Yes, yeah. Your slide us on the diabetic prevention trials shown much effectiveness with the glitazones, pioglitazone.
Yes,
Rosi.
yeah, including the DREAM trial, right? The first molecule to show benefit was troglodyazone.
71, 81 and 61%.
Yes, yes, the remission rates were very, very high. But of course, it was withdrawn because of the hepatic side effects, and therefore.
Actually, we can try small dose of pioglitazone in our practice for all pre-diabetics. As for the
Yes, but the pioglitazone dose that was used was 30 to 45 milligrams. Sir. So many times we don't have the affordability to use 30 and 45 milligrams for patients, especially with pre-diabetes. That's the one.
7.5.
Yeah.
Professor Lakshmanan sir said a small dose of pioglitazone, well taken, but for the weight gain,
I don't know, that age group.
Based on patient selection we can do, I think.
Can I see the
sir.
slide, madam?
I think there was a combination of metformin and pioglitazone with GLP-1 receptor agonist. Sir. So it's like a masala. So I think probably the good things of every single drug is being taken care of, and they neutralize the side effects each other.
And again, you said we need to wait for HbA1c of 6. Why not you said IGT is the earliest. Why can't we start the precautionary steps?
The benefits with regards to reduction in complications of cardiovascular disease, the clear data is in the A1C is more than 6%. But if you are really looking at reduction in the incidence of type 2 diabetes, you can start right at the time of like diagnosing pre-diabetes at A1C of 5.7.
Regarding pre-diabetes, we can control the numbers with drug, but we cannot control the associated macrovascular complication by simply instituting a drug therapy for diabetes. That Dr. Adeline also in her slide put the complication rate decreased by 48% macrovascular events in Chinese quad-ring study in follow-up. Whereas our other drugs like metformin and others, it can prevent progression to diabetes. It can, but it will not have the same say over the control or prevention of the intertwined macrovascular complication. For that, definitely the patient should be on lifestyle modification, and there are some ongoing trials whether calorie wasting through SGLT2 inhibitors will address the root cause of pre-diabetes and reverse or prevent macrovascular complications.
So font of time, we are just completing the for further any, sorry. Sorry.
Should I complete?
Last
30
question.
30 seconds we have. So Adeline, congratulations for wonderful deliberation. You are very nicely focused on when you compare IFG versus IGT, you said IGT has more risk of atherosclerotic versus IFG, if I'm not wrong, if I'm not mistaken.
Yes,
The criteria.
And that further endorses the postprandial hyperglycemia, which our people missed out, and Caucasians, they don't focus on postprandial hyperglycemia
Exactly.
at all. So this is another message, we are already high carb eaters. And with that, if you have this data, this should be emphasized more and more in the
And this is a
clinician's
Western
mind.
data, sir. This is a Western
This
data.
is
But
Western
I told
data,
IGT was
Western data, but
associated.
they are
Yes,
traditionally monitoring only fasting blood glucose
Yes.
in most of the trials. So I feel now we should have more dedicated trial on postprandial hyperglycemia
And
on various
Adeline, we
situations.
have more of postprandial.
Yeah,
Yeah.
that's very good data. Thank you very much.
Thank you.
Thank you all. We are just closing the session. Thank you. Thank you, the speakers, my co-chairperson all.